We are live. Please.
Very good morning to everyone. We warmly welcome you all to the webinar on ocular tuberculosis. This webinar is being organized as a part of the World TB celebration by the Uveitis Society of India. The program director for today's session is Dr. Soumavya Basu, who is the scientific chairperson for Uveitis Society of India, and he head the Uveitis services at LV Prasad Eye Institute Network. He'll be addressing the several unanswered and challenging questions in ocular tuberculosis. We are honored to have an eminent panel of experts who need no introduction to this distinguished audience. In alphabetical order, we have Professor Amod Gupta, Professor Emeritus at Advanced Eye Center, PGI Chandigarh, and Dr. Jyotirmay Biswas, Professor Emeritus at Shankar Nethralaya, Chennai, and Dr. S.R. Ratinam. She is a principal at Aravind Eye Hospital, Postgraduate Institute of Ophthalmology, Madurai. And we have Professor Vishali Gupta. She is the president of Uveitis Society of India and professor at Advanced Eye Center, Chandigarh. Today's discussion will focus on aspects of ocular tuberculosis that are not commonly covered, promising an insightful and enriching session. With this introduction, now I hand over the proceedings to our program director, Dr. Basu. Over to Dr. Basu.
Thank you, Dr. Padma. Good morning, everyone, and thank you for joining today's discussion on the occasion of World TB Day. For those of you who are not aware, we celebrate World TB Day on the March of 24th, which is in fact 2 days from today, because that was the day in 1882 that Robert Koch, who also postulated the famous Koch's postulates, announced the discovery of the tubercle bacillus. Of course, it was named Mycobacterium tuberculosis a year later, but this was the momentous day when the tubercle bacillus was first associated with the disease. It's also interesting that just a year from that announcement, von Michel, again from Germany, identified tubercle bacilli in the eye lesions. So the journey of ocular tuberculosis has been nearly as long as the journey of Mycobacterium tuberculosis. This gives us a good perspective why we should discuss ocular TB on the occasion of World TB Day. To discuss this, we have a wonderful panel with us. Dr. Padma Malini already introduced them, but I think to almost everyone who has joined us today, all these people need no introduction. Their combined experience in not only ocular TB, but uveitis in general, or even ophthalmology in general, is probably bigger than almost any other group of 4 people anywhere in the country, or I take the risk of saying that maybe elsewhere in the world. And they also bring with them a lot of wisdom, which they are going to share on the questions that we are going to ask today. And this is also a time that I thank the Uveitis Society of India, Dr. Padma, Dr. Partho, for giving me this opportunity to moderate this session. Now, the questions that we have selected today are generally unanswered questions. It's not that they are new questions. All of us keep asking them when we discuss ocular TB amongst each other, but we don't talk about the answers. What might the answers be? There is insufficient literature on these questions. We have tried to form balanced arguments on each of these questions. So there are both points in favor as well as against a particular argument. And then we'll try to take support from other specialties. For example, the brain, the bones, the lymph nodes, where TB also affects other than the lungs. The goal of this session is not to provide the answers to each of these questions, but to give us the points that will ensure critical thinking in future discussions. So the questions that we have chosen are in ocular tuberculosis, do we have Mycobacteria in the eye or elsewhere? What happens to the tissues in ocular TB? Do we call it confirmed or presumed tuberculosis? How do the anti-TB drugs work in the eye? And what do we do if there is inflammation after completion of anti-TB therapy? Now, you'll notice that these questions are not the usual ones which are discussed in any TB meeting anywhere in the world, which are typically related to the clinical signs, the imaging of ocular tuberculosis, diagnostic tests, and treatment. Now, all of these are very important as well, but somehow the ones that we have uh, taken today, they fall through the gaps and therefore they are not discussed. You will also notice that if we understand these 5 questions, we'll be able to understand the more relevant ones to our clinical practice even better. With this, I move on to the first question that we have scheduled for today, which is, when we call something as ocular tuberculosis, are we dealing with mycobacteria in the eye or elsewhere? And there are points both in favor of this, which is that there are several histopathological studies from a long time ago as well as recent ones, which tell us that there are mycobacteria in the eye. There's a lot of PCR data from all across the country and even outside the country. And then we get our insights from other forms of extrapulmonary TB, where we see inflammation which is directly connected to mycobacteria. Now, to counter this argument, we can always say that in most cases, or nearly all cases of ocular tuberculosis, we do not have any microbiological evidence. And there are those cases that come without any granulomatous inflammation as well. And I'll give an example of this later. Now, some of you might say that the ones that go for the histopathological studies are generally end stage ocular TB, and therefore they have very acute inflammation and a lot of necrosis, and these are the ones where you're likely to find mycobacteria. But if you look at recent literature, for example, this one on serpiginous-like choroiditis, there is clear evidence that there is granulomatous inflammation in the choroid, including the choriocapillaris, in patients with serpiginous-like choroiditis, or in a patient with retinal vasculitis, there is clear evidence that there are intraretinal granuloma in these patients. In fact, there's a very old study from a time even before the discovery of tubercle bacillus. This is from 1867, where this author Conheim reported tubercles in the choroid having a structure very similar to tubercles elsewhere in the body, and therefore postulated at that time, even before the discovery of the bacillus, that the way tubercles affect the eye is very similar to the way tubercles affect other parts of the body. In fact, this paper is available free on the internet. I would suggest that you go download this German paper and get an English translation as well. So with this background, I take this up with Professor Amod Gupta to start this conversation and tell us more about his thoughts on this question.
Well, thank you, Soumya, for a very nice introduction and introducing this webinar series on some of the most controversial aspects of uveitis, and leading the pack of uveitis entities. TB is the one which has been the most enigmatic. Tuberculosis is not a disease discovered by Robert Koch. He only discovered the acid-fast bacilli, or the Mycobacterium tuberculosis, the causative organism of tuberculosis. I think if you look back at some of the paleontological data, people have seen in the mummies the presence of Mycobacterium tuberculosis using very, very modern genetic technologies, that it has been there for several thousand years. And this is a very unique organism, and because of its uniqueness, because on its own, it has so many avatars, if I can use that word, that it has so many, it could be hiding, it could become dormant, it could be persisting despite your antibiotics, or it could lie there almost practically dead forever and not be able to. And that's what majority of the people carry who have the infection, that they will carry that bug somewhere in the body, and it may remain so lifelong. So it's a very enigmatic organism. I would say that. In the eye, as you rightly pointed out, even before Robert Koch discovered the bacilli, in fact, one of the papers I'll refer, again, the full text is available, by Haab. In 1879, just before the discovery of AFB by Robert Koch, this guy had reported pathology of 7 cases of choroidal tuberculosis. And then this discovery so he wrote that paper, and soon after the bacilli were discovered, he went back to his the blocks, the pathology blocks, and discovered that all his patients indeed have the demonstration AFB in those in the same set of slides. So unless you know the presence of bacteria or bug or causative organism, you're not really looking for it. And that's what happened. And in fact, we have, even going back 25 years earlier, we have the pathology reports by von Graffe, by Mainz, and Leber. Mainz is in fact the one, in 1858 or somewhere, credited with describing the description of tubercular granuloma was very well known. And very interesting fact that before the turn of 20th century, in the 19th century, people believed that the portal of entry of tuberculosis is via the eye. And that's how they kind of enucleated the eye to stop the spread of tuberculosis. That given that they didn't know how it was entering into, though Robert Koch had discovered the bacillus, they didn't know. So it was, I believe, that looking at all those historical aspects, I believe it has been there. And, it was only more recently that once we realized more phenotypes of ocular tuberculosis, that the confusion arose. There has never been a dispute about the choroidal granuloma occurring in patients with disseminated tuberculosis, and that is where you have been able to demonstrate in pathology slides. You have been able to demonstrate the presence of AFB or Mycobacterium tuberculosis in the choroid. So that aspect, where it produces a choroidal granuloma, it produces a caseous granuloma, it produces some kind of an abscess and reactive exudative RD, that I believe, and that has been our experience. Majority of these patients, you can show a disseminated TB state. So there is no question about the presence of AFB in those patients, where you have frank tubercular granuloma and disseminated TB. Where the confusion arises to my mind is where we see the manifestation of MTB more in the form of a hypersensitivity response or an immunological response to the presence of M antigen. And since many of these patients we have been able to demonstrate, and so many labs, your lab, Dr. Jyoti Biswas lab, and Madam Ratnam's lab, they have all shown that PCR is positive in many of these patients. Maybe sensitivity is not very high, so we don't recommend as a screening tool. But the mere positivity by PCR, by real-time PCR or quantitative PCR, by conventional PCR or multiplex PCRs, and a variety of PCRs. Now we have from our lab, we have shown the RNA, we have shown even the transcriptomes more recently. So there is no doubt to my mind that MTB is present in the ocular tissue, albeit in a very, very tiny number. And that has been the case in all extrapulmonary TB, except pulmonary TB, where you can demonstrate AFB in the sputum or in the the aspirate from the bronchial tree, these bugs are very, very difficult to demonstrate in extrapulmonary sites, be it is the brain, be it the eye, be it the testes. These are the the kind of where we have immune privilege, these three sites in the body where ordinarily the organism will not be able to find entry. So it has been difficult, so has been in the children. So all these patients of external TB have difficulty in demonstrating TB, but since in some cases we can see a bit like Dr. Narsingh Raw's study on pathology of 42 eyes or so, in one odd patient you would see AP, and other cases you might have PCR positive. So that's how the Paucibacillary concept came. So you have a multibacillary in choroidal granulomas and Paucibacillary in more immune mediated response. So I think it helps to clarify the concept, or I confuse.
Yes, thank you very much. But so now I'll take the other side of the story, and for this I would request Dr. Biswas to share his understanding. And for this, in fact, I am taking one of his case reports, which was published a while ago in 2008. Now, this is a patient, a child with abdominal tuberculosis, microbiologically proven, and the left eye, in fact, shows a healed choroidal lesion. But the right eye shows what is more like a frosted branch angiitis, diffuse perivascular sheathing in all quadrants without any without any granuloma formation. At least is that we have very strong evidence that tuberculosis is driving this condition, and yet, at least clinically, again, you do not see any evidence of granuloma formation. Now, the question is to Dr. Biswas here: why would you think such a phenomenon is occurring, and that too differently in either eye?
I think Dr. Biswas is not online.
Okay. Dr. Ratinam, could you take this one?
I'll take this.
Yes.
It is
Actually,
okay. I can hear you. I can.
Yeah,
Okay.
he's come back.
Muted.
yeah.
He's come back.
So
Please continue,
Yes,
sir.
ma'am.
this was a case of tubercular granuloma, choroidal granuloma in one eye and frosted branch angiitis in other eye. The patient had a proven abdominal tuberculosis. And this led us to believe that this frosted branch angiitis picture which you have seen is a kind of a tuberculosis phenomena. Tuberculosis in immunologic reaction, probably tuberculosis. We did not see any other evidence of tuberculosis. This is an extrapulmonary tuberculosis only, and the patient responded to a course of anti-TB treatment, and we gave steroid also. And what we saw is a complete resolution of inflammation. As you see in prostate branch angiitis and CMB retinitis, similar with ganciclovir treatment, intravenous or intravitreal, complete resolution occurs. That way it showed the complete resolution. So I was quite convinced that this is a tuberculosis infection. This is caused due to the tuberculosis. May not be that a direct infection of the tuberculosis, maybe an immunologic reaction producing retinal vasculitis, as we see in case of other forms of retinal vasculitis like TB retinal vasculitis or Hill's disease, where we did not find any organisms anytime. So we have done the vitreous specimen culture from the vitrectomy specimen of Hill's disease patient, which are called tubercular retinal vasculitis. None of them we could develop organisms from the culture. So I think this immunological phenomena occurs in this kind of disease.
So I'll, kind of extend this conversation, and this one goes to Dr. Ratinam. When we say immunologic phenomenon causing a disease or hypersensitivity reaction causing a disease, now any kind of inflammation, in fact, a lot of non-immunological conditions as well, from anything from atherosclerosis to Alzheimer's disease, all of them have an immune component. So to put a blanket statement for the left eye of this particular patient that this is an immunological phenomenon, how do we explain that? And one of the things that has always concerned me is that we are able to identify this in the eye because we are able to see the fundus, as against those people who are examining the brain or the kidneys or any other parts of the body. In
Yes.
fact, in the kidney, there is a disease called as Ponset's disease, which has features very similar to what we are seeing in the left eye of this patient. So, Dr. Ratinam, do you think we rush a little bit in calling it an immune-mediated phenomenon without trying to go a little further in explaining why this is happening like this in the eye without an obvious, I'm stating again and again, an obvious granulomatous response?
Yeah, when the other eye picture is towards choroidal granuloma, we are very comfortable in saying that it is bacillary induced. But whereas in the vessels, all the vessels are inflamed uniformly, and there is no difference. Like one vessel is having a sheathed vasculitis with pigmented scar. When I see a pigmented scar or a lesion, active choroidal lesion near the vessel with vasculitis, I am comfortable in calling that case as bacillary induced. Whereas this frosted branch angiitis, we see in viruses, we see in post-febrile retinitis, all causes, and we see in tuberculosis as well. That is the reason I am also very much convinced, as Dr. JB, that this frosted branch angiitis is immune related.
Soumya, can I?
Yes, ma'am. Yeah.
I think when we are talking about the immune mediated, there is a beautiful recent publication in the ophthalmology science by Karagoz and Marion Monk, where they have done the mathematical, modeling using CABS-DEC web. And what they have found is that there is a model of molecular mimicry, which they have found that there are at least 25 proteins in the Mycobacterium, main of course is ESAT, and then there are others, which have a very close resemblance with the proteins they identified from the RPE and photoreceptors. And the focus in the body, like even if there is a mycobacterium somewhere in the gut or in this, it does not have to be a very large focus to induce molecular mimicry. It can be a just very small focus which body is containing itself and which is not even producing a clinical disease. But if you are exposed to it and you are carrying those cells in it and they go and sit on the proteins which are similar to this, it's likely to cause autoinflammation as well as autoimmune response. And I think that's what is happening because we are dealing with two kinds of spectra. On the one end of the spectrum is where we find the Mycobacterium TB multiplying in the eye. And those are large abscesses, tuberculomas, and like you said in the beginning, those are the eyes which are enucleated. On the other hand, when we talk of retinal vasculitis, serpiginous like choroiditis, they are more explained on the basis of molecular mimicry. And we just have two reports which showed that serpiginous choroiditis patient had histopathologically proven. I'm not talking of PCR, histopathologically proven. And even there, if you look at the edge of the serpiginous, it's more like a granuloma rather than what you would call it as serpiginous kind of a choroiditis. And I think these are two different manifestations. So probably there is not a single answer that we are finding the bug or not finding the bug because our clinical experience is enough to indicate that these two are very different. and they should be treated, or, they should be segregated?
So one of the immunological concepts that I may add to support what you just mentioned is that while normal inactivated cells, T cells, which are circulating, they will not be able to cross the blood-retinal barrier. On the other hand, if you have activated T cells in the periphery, and this has been shown very nicely by Rachel Caspi and a group in the context of the gut microbiome, if T cells are activated in the periphery, they are easily able to cross the blood-retinal barriers. So this might be connected to our understanding of T cells getting activated in the periphery and then coming into the eye and causing inflammation.
I agree.
I'll just
Tommy.
Yes, ma'am, sir.
Yeah. I'll just give what is my understanding of before you go to that, the portal of entry of MTB is via the lungs. So it's practically impossible to get TB except for a one odd case of GI where they by ingesting milk or contaminated, or they might get that GI infection. A large majority get pulmonary tuberculosis. And what is happening there when you are getting a pulmonary, the MTB is getting phagocytosed by the alveolar macrophages, by the antigen presenting cells and other macrophages. And once they ingest the MTB, they are moving to the regional lymph nodes, to the hilar lymph nodes. Now, that is where the main factory of MTB antigen is located, where a kind of a reservoir. Now, this becomes the MTB bug likes to go there, doesn't want to remain in the lung. It wants to go to the lymph nodes, which are in the so-called the hilar lymph nodes, where this will present to the T cells, will have those T effector cells and stuff like that. And they form a kind of a reservoir from where, from time to time, these APCs or antigen presenting cells and macrophages and others, they will be released into the circulation. Now, once they are getting into the circulation, they may get trapped into the choroid. Now we have seen this work by the Indonesian group, where they have shown that even the retinal vascular endothelial cells, they welcome these, APCs which are loaded with MTB or with the phagocytes and also the free MTB. They all come and they will pass through. The endothelium doesn't keep it for long, but it passes them on to the retinal microglia, which are the resident antigen presenting cells in the retinal structure. That explains, why these TB vasculitis patients have a perivascular kind of a granuloma, which we had shown earlier. Now your work shows that, and we have those rare cases of retinal granuloma also explained by this mechanism. The
Sir,
activated
I have a
Yeah.
question for you.
Yeah.
There are TB patients which have perivasculitis and which have typical perivascular granuloma,
Yeah.
periphlebitis. But then there are another subset of TB patients which have diffuse capillary leak, fern-like leak, which we earlier related only to Behçet's, and now we know that it's not really typical, which have capillary non-perfusion, and it's more of a pan-occlusive kind of a picture. So my question to you is that if Mycobacterium, like we always thought it was coming locally, perivascular, how come it is producing such a pan-vascular response
No, I think,
affecting capillary
Jali,
and
I think it's not the TB bug. TB bug
yeah.
free bacilli will be coming only when there is a, sudden spurt, there's a bursting of focus in the lung, it disseminates. So there would be, but by and large, it is coming as, Trojan horse mechanism where they are engulfed by these macrophages or APCs, and they are sitting inside cozily and go there, get into the RPE, get into the endothelial cells and others. But the main inflammation is not by the bug itself.
True.
It's by the cytokines which are released.
Cytokines.
They make the cytokines make these endothelial cell more sticky. They will have those T cells and others, and later even the granulocytes, they will come and they will occlude. They will cause breakdown of the blood-retinal barrier, and the endothelial barrier is broken, and you have those what you calling leakage, which is fern-like or whatever. So it's a spectrum, I suppose. And perivascular, what you are calling as frosted branch, is nothing more than a perivascular collection of mostly lymphocytes.
Lymphocytes.
Yeah, and now we can only speculate because they have shown it in brain, because that's where they have got the pathology from people who died of TB meningitis, and they have shown that they have an ischemic process mainly because the arteries get involved there, and in our case because the arteries are not involved, and they are the veins basically, which are easily compromised compared to the arteries in the eye. But in the brain, because of the meningitis, they are going into the vessel walls, and then they are creating endothelitis and occlusion thrombosis. So all those thrombotic phenomena would occur, and this cause infarcts in the brain. Whereas in the retina, we have that counterpart is a capillary non-perfusion, and once you have capillaries non-perfusing, the arteries stop flowing. That's why you see arteries also don't perfuse, because there is no if there is no outflow, there is no inflow. That's the principle. It becomes static, and they don't see on fluorescein angiogram. So I think it's a spectrum. It'll be safer to call it a spectrum. But immune mechanism doesn't mean only the cells. It means most of the damage we have seen is caused by the release of the cytokines and the chemokines that are released by these cells, activated cells, which help migrate. The migration of the cells moves along a gradient of this has been shown. So all these experiments have been done in the animal models. Most of these have been done not in the eye, but eye is no different from any other organ. Okay, and we can see another thing we need to understand is it's not a systemic disease, it is a compartmentalized disease. Even the granuloma is compartmentalized. I think Basu would come to that later. That it's something is happening somewhere, healing is occurring, other places activity is going on, and immune reaction is going on, cytokines are being released. So one eye getting a granuloma and the other eye getting a vasculitis, or in the same eye multiple phenotypes occurring simultaneously, I'll not be surprised at all. Yeah. So we should talk in terms of a spectrum of manifestations of these.
So just to complete this conversation, I included this study which was published a few years ago from the US, of all places, a TB non-endemic country. And these are about 10,000 cases from Texas. And these include both pulmonary as well as extrapulmonary tuberculosis, as well as those that had combined pulmonary extrapulmonary tuberculosis. You will see that there is a section of patients, about 14% of them, who had extrapulmonary tuberculosis alone. And these patients had a less likely history of TB contact. Only a little over a third of these patients had abnormal chest radiographs, which mean even healed tuberculosis. And just 1.4% of these patients had a culture positive extrapulmonary specimen. And, since we're talking from the US, obviously, these patients had been investigated very well. And we are, mind you, talking only about patients who had extrapulmonary TB alone. Now, these numbers are very interesting because if you look at the ocular TB data, and especially from the COTS study, you see that almost 3/4 of these patients have no history of any pulmonary or extrapulmonary TB. The chest X-ray is positive in any way only in about a quarter of these patients, and even the CT scan is positive in about only 2/3 of these patients. So 1/3 of these patients have nothing in the chest at all. So this is something that we probably need to pass on to our pulmonology colleagues and even other internists who are going to treat our patients with the anti-TB therapy. Dr. Ratinam, what has been your experience on this background?
Yeah, I totally agree with you because it is very less number of patients are positive in X-ray and a little more sensitive CT scan. And specifically, we pick up a mediastinal lymph node more often in CT scan than in X-ray. So ultimately, it always the clinical picture that is very, very important. Even if we don't have any evidence in the chest, we start screening the abdomen and we start screening even the, we have few cases of cerebral tuberculosis or meningeal tuberculosis and skull tuberculosis, other lymph node tuberculosis, tubercular osteoarthritis. So it is the overall search for tuberculosis. It is not only pulmonary, it has to be all other extrapulmonary other than eye. So when we screen like that, we get very good clinical evidence. So that is my experience. Because TB archidematitis, TB salpingitis, mesenteric lymph nodes, mesenteric TB lymph nodes, and we have even proven mesenteric lymph node tuberculosis with ocular tuberculosis. And we have a biopsy proven osteoarthritis with ocular tuberculosis. So it is not only pulmonary system, it is other extrapulmonary system other than eye.
Yeah, this was the question maybe I could put to Dr. Biswas about...
Take some. I've seen spinal TB producing ocular TB, or abdominal TB producing ocular TB. But into a very practical, when you see a TB granuloma or TB abscess or TB vasculitis, it becomes very laborious and expensive to look for every site, including that if you need to do a PET scan also to rule to rule out the tuberculosis in other sites.
Sir, we never do PET scan for TB because it's very radio hazard procedure, but we go according to the symptom of the patient. When we ask, do you have any other problem in your body? They say, I have a joint pain here, which is there for 3 years, something like that. And another patient had testicular swelling where CMC Vellore wanted to have biopsy. He refused and came back. Then we proved that it is testicular TB as well as ocular TB. So symptom-wise, we can pick up. We need not do PET scan. We need not screen everywhere. If they have history of epilepsy or if they have chronic headache, then radio diagnosis of brain. If they have abdominal pain, one of our patient gave a very interesting history of whenever he is in prone position at a temple, when he is praying, he had abdominal pain and he had mesenteric lymphadenitis. So symptom-oriented investigation will help us.
That's a great point, Dr. Rathinam. Dr. Vishali, just to complete this conversation, do you think we need to shift our focus of screening our patients for TB outside the eye from pulmonary to extrapulmonary TB? Because, there's a very interesting study from Thailand which shows that the incidence of ocular TB in patients with proven extrapulmonary TB is much higher than the incidence of ocular TB in patients with proven pulmonary TB. So your take on this point?
Soumya, I live in a practical world. So I'll tell you what I do in a practical world. When the patient is sitting in front of you, honestly, you don't care where the T cells are walking in and out from. You look into the eye, you do imaging, and we have beautiful imaging biomarkers now, which will help us differentiate TB from non-TB. I would make a list of differentials from eye point of view. I will rule out other possible etiologies, like Dr. Biswas beautifully showed that he had a possibility of viral in a frosted branch case. Now, if you have such a possibility, I will not do anything first to rule out other possible etiologies, which can be done on imaging in 90% of the times based on the current scenario. Yes, after that, I think it is tuberculosis, and now you want to see what to do next. And Dr. Ratinam explained beautifully that we have to talk to the patient, we have to get the history of family exposure, and you will wonder sometimes some Dadaji somewhere had, which they don't think it important to tell you, but a history of exposure will be very important. General physical examination and symptoms. We do Monte's, IGRA, and CT chest just to look at the signs. And if I find those signs and nothing on clinical, I will not honestly look for extrapulmonary TB if the patient is asymptomatic. Because even if there is some focus somewhere and I'm going to give my anti-TB treatment, it's going to take care of that. But if the patient has a particular symptom which is belonging to GI or somewhere, or if I'm not getting a clue from these investigations and I want to give ATT treatment, but somehow I need something to hang on to, those are the patients I will go for extrapulmonary investigation. And I'll give you an example of a young girl who was working in a mycobacterium lab in a premier institute, and she developed serpiginous-like choroiditis, and she went all over and all the tests were negative. That is the kind of the patient where I know there has been a solid exposure and all Monteus and all are equivocal. I did get the PET scan, which showed there was in the parotid active focus. And she told me, oh, I had Warthin's tumor. And we retrieved the slides and we found that it was actually a parotid gland TB. But looking at all the patients of TB and looking for extrapulmonary, I personally will not do that.
I think that's a very important take-home point, that you start looking for the other sources, and you just mentioned also about the important history of TB contact. Then all the other things like looking at other sites of extrapulmonary TB, only when your other important stages, including the clinical signs, the imaging biomarkers, the initial test that you do for the tuberculin skin test or the IGRA test, when these are equivocal, that is probably when you move on to the other ways you can connect our inflammation to tuberculosis. I think, this was probably the most important question that we're going to cover today. So it has taken a significant amount of time, which takes us to the next question, which is the tissues in ocular tuberculosis. And the question is, why is the disease so heterogeneous, unlike other extrapulmonary TB? And there are various ways we can try to explain this. One is it because there's a variable immune response inside the eye? Maybe the one with retinal vasculitis is different from the one with serpiginous-like choroiditis. Is it because we have greater visibility in the eye? And this thing has always bothered me. Maybe one reason we are not able to connect ocular TB with other TB is because we see a lot more in the eye clinically, which other specialists are not able to do. And is it because there is a lot of diagnostic uncertainty? So some of the conditions which may not be TB at all, we are calling them tuberculosis. And since we are talking about tissues, I think I'll start this question with Dr. Biswas, because he has the most experience on the histopathology of ocular tuberculosis.
So actually, what we have seen, that tuberculosis is such a variety of responses, from miliary tubercle to caudal tuberculoma, subretinal abscess, then pan-uveitis, then retinal vasculitis. That it's difficult to explain by that single immune mechanisms producing this kind of several processes. like, tuberculoma, you will be having a granuloma abscess formations, and there will be epithelial cells, macrophages, etc. What is the vasculitis? We might be having only lymphocyte response. Like in Hill's disease patients, epiretinal membrane or retinal tissues, we have seen that lymphocytic response, only these things, and series suppressor cells, we have seen. But when we had a case of abscess, of tubercular abscess, like subretinal abscess, we saw that frank caseation necrosis and epithelial cells, giant cells, and plenty of acid-fast bacilli in few cases. And this response is quite variable. And I don't know that whether a single mechanism can explain.
So, a very connected question is this issue of calling ocular TB as paucibacillary. Now,
Yes.
Professor Amod Gupta just mentioned about the study by Dr. Narsingh Rao's group published in 2011, where large areas of necrosis were seen in enucleated specimens of ocular tuberculosis, and only one or two organisms were found near the areas of necrosis. So it was very easy to call this as a paucibacillary disease. But would you think that in these patients who have such enormous amount of inflammation in the eye, such extensive necrosis, do you think that we are not trying enough to identify the organisms? Because if you look at the same study, the number of copies of tubercular DNA that were found on the real-time PCR in some of these patients were very high. They went into
Yes.
thousands. So, do you think again we are, jumping the gun in calling this disease as paucibacillary and drawing all our conclusions from this? I think
I would say that mostly paucibacillary, but it would be possible that there could be a non-viable acid-fast bacilli or atypical mycobacteria can also be possible that produces a caseation necrosis, but organisms are very few and far between. Mm, um, so there is a paucibacillary situations is though clinically I have not seen in except one case which has got a myriads of acid-fast bacilli. Majority of the patients I could see only one or two bacilli, acid-fast bacilli, and that was also in the RP in the phase,
Professor Amod,
RP level. So I think it's difficult to explain that so much of caseation necrosis caused by just few acid-fast bacilli. There must be something more. The non-viable tubercle bacilli or degraded tuberculosis bacilli, which are not visible, producing this kind of reaction. Non-viable Mycobacterium tuberculosis.
yes. Thank you. Professor Amod Gupta, sir, your thoughts?
I think it's immaterial whether we see multiple bacilli, and in fact, if you ask Dr. Narsingh Rao, he'll say if you see a lot of organisms, they're likely to be, atypical mycobacteria rather than, or NTM, rather than Mycobacterium tuberculosis. It typically causes all this pathology in the presence of only a few organisms that are required. How the body reacts to how much immune response it mounts will vary. It varies from the lung and the extrapulmonary sites, because extrapulmonary site, including the eye, they are not designed to contain or kill the bacilli. They don't have robust immune mechanisms to kill the organisms, unlike the, because lungs is only one part of the body where all the time it is exposed to bugs which are getting eliminated. So they are all the time in an activated state your macrophages and others. So that's a different story, where they can multiply and they can be contained and they can all be, cavitary formation and others. Whereas in the eye, only one or two or three bugs, if you see, fine. I don't think it should be compulsory to demonstrate, like pulmonary TB, to show a presence of one or two or multiple AFB in the ocular tissues. Other thing which you asked about the tissues, I think we should also be able to differentiate when we take eye as a whole, the immune privileged part component of the eye and the non-immune privileged. Like choroid is not immune privileged. The
Yes.
choroid has fenestrated capillaries, the high flow, all these organisms and the APCs and lymphocytes, and they get trapped. Okay, and they have their own resident, immune cells present in that area. So is in the anterior scleritis, when you see, which is a sclerokeratitis or anterior TB scleritis. So anterior sclera, because by virtue of the subtenon area, which is highly vascularized and brings in all these, it will produce necrotizing caseous granulomas, and it will create that picture. Now, once you go inside the eye, inside the RPE, and the vessels, that you find that there is a immune privilege. Okay, and that is how you are getting more of these lesions which arise from the RPE, and probably the choriocapillaris gets affected because Vishali's group only has shown that, by OCTA angiography, that in serpiginous choroiditis that starts healing, the choriocapillaris blood flow is restored. So there's no destruction of that. It's only a functional block of the choriocapillaris flow. But the main pathology is probably arising in the RPE, where the mycobacterium is sitting and inducing all those changes in the inflammatory changes of serpiginoid, like choroiditis, which is by and large immune mediated, but immune mediated which is driven by the presence of MTB. Okay, it's driven, it's a infection driven. And I think we are heading towards times when all immune reactions would have the kind of organism identified which is driving that immune reaction. So there is not much of non-infectious uveitis in coming years or decades. We'll be able to demonstrate once we start looking for, and already that NGS is showing some of these patients that there are some unique organisms which are present in these eyes, which might be driving the autoimmune reaction, so-called autoimmune, which are basically immune. So I think I will not go by the quantum of bacteria, but the reaction they are producing.
Right. So thank you. I think, the last point which you mentioned, that it's a very deep philosophical point, that, till date we have been talking about uveitis as infectious and non-infectious, or infectious and autoimmune. And gradually, as our tools improve, and you mentioned about NGS, we'll probably realize that a lot of so-called autoimmune uveitis are actually infectious uveitis in another form. In fact, I would recommend the audience to refer to a perspective published in AJO, I think 2017, by Professor John Forrester. It's called Autoinflammation and Autoimmunity in Uveitis. It's a wonderful, text that explains this point very well. So this brings us to the next question, and this is something that also comes up, but we don't discuss it very often. What do we call the ocular TB that we see in our patients? Do we call it ocular TB alone, or do we keep calling it presumed ocular tuberculosis just because we do not have the evidence of mycobacteria from our samples? Now, I have divided again in two groups. One, the points favoring the idea of calling it ocular TB alone. And this comes from the insights from other extrapulmonary TB. Like, you never call presumed TB meningitis or presumed GI TB, presumed pediatric TB. You just call it what it is. Then, what I like very much about the COTS nomenclature supporting the idea of calling it ocular TB alone and giving up on presumed tuberculosis. As we understand, this causes a lot of ambiguity in communication. When you make this statement that I have diagnosed presumed ocular TB, the patient thinks that the doctor is not sure what he's talking about. And when we refer these patients to our colleagues in pulmonology or internal medicine, they also feel that the ophthalmologist is not very sure if this is truly ocular TB or not. Of course, we have so much experimental evidence from guinea pigs, which are aerosol-infected models of ocular tuberculosis, mice and zebrafish, all of which showing the organism going from the circulation into the eye and causing inflammation. Now, to counter this argument, of course, like in the previous points, again, we have the absence of microbiological evidence to call it presumed. Maybe when we combine these two, we asked us.
Is there a problem with Soumya's audio?
Second point may be and when we combine these two, Dr. Vishali, your thoughts on this?
Okay. So Soumya, personally, I feel this terminology of confirmed versus presumed came up because we are always looking at pulmonary TB, as a role model, I can say. So let's see what pulmonologists call it a confirm. They would call it a confirm if you can see Mycobacterium on smear, on culture, and later on, of course, the NAT and the PCRs were added. But there is a subset of patients in internal medicine, for example, fever of unknown origin. Now, there are multiple causes for this, and TB could be one of the causes, which they are calling it presumed. However, they have no confirmation that it's TB. So they would like to put some label on it that, well, it could be suspected TB. And it was actually called TB suspect, and later on the word presumed came. And I think it was a red rider that, okay, this patient could have TB, so don't give steroids just like that, and maybe add ATT as an empirical therapy to see whether patient responds or does not respond. That said, with the evolvement and how the extra-pulmonary TB evolved, no subset of specialty other than pulmonary used the word presumed because they would rule out other etiologies and they will say that it is TB or not, whether it is bacteriologically confirmed or not confirmed, but by and large, they will put a label to it that TB. For the ocular TB, I think we had a lot of this discussion during a nomenclature for the CODS, and I totally agree with you that once we say it is TB, for us, it's not even a question because more than 60 or even more are immune-mediated responses we are talking about. We are not even talking about very infective TB, where we say that, okay, don't give steroids or we want to label it as infective uveitis. In fact, if you ask me, not only the word, but over a period of time, I don't think these words infectious versus non-infectious uveitis would stay because you may find an underlying trigger for infectious uveitis, but it's not truly infectious in the true sense. It's still triggering an autoimmune or autoinflammatory response. You still need to give steroids and maybe immunosuppressive therapy. And the role of specific therapy is restricted just to reduce the recurrences. It doesn't have much role to play for the primary episode or the given episode because that is driven by the inflammatory response, and the ocular damage to the structures is being done by inflammation. So you got to take care of the inflammation. So to me, the word presumed is kind of redundant. Because if it is a tuberculoma, you don't say it is a presumed tuberculoma, you just say it's tuberculoma, you know. So I would not be in favor of using the word. If you have ruled out everything and everything is pointing towards TB as an etiology, and you are convinced you want to treat a treatment, it should be given a name of ocular TB. Treat it. You may be wrong. It may not be TB. So what? After 3 months, you revise the treatment, or you say, okay, I missed the diagnosis, I made a wrong diagnosis, and you revise. But while you are making the diagnosis, at least be on some firm grounds that, okay, I'm not very sure, but I believe it's TB. Only then make. Just adding the word presumed indicates that you are not sure. You're looking for a safety net, something to hang on to.
I think the last point that you made is so very important. Okay. We are always worried that this may be not TB and we may end up in another diagnosis. That's fine. But once we are starting treatment, I don't think it's fair to call it presumed TB and then start the treatment.
Yes.
Either for the patient or for our colleagues, who are going to start this treatment. So that's a very important take home for the audience.
Can I add something?
Yeah, please.
Yes, sir. Yes, sir.
So to me that presumed TB, when you find the PCR is positive for TB, I will call it as a TB. And though PCR has got a false positivity and false negativity, but for all practical purposes, if my clinical features suggestive of TB and PCR is positive, I'll call it as a TB, Paradoxical TB anterior uveitis, TB intermediate uveitis.
Sir, since all of us are...
Soumya, I don't know from where this presumed word come, the nomenclature, because if you go by the classification of pediatric tuberculosis, they will say if they find the evidence, where it's very difficult to find in those patients, it closely mimics ocular tuberculosis, very difficult to demonstrate the AFB. So they go by the definitive diagnosis, possible diagnosis, and probable diagnosis.
Yeah.
So they don't use the word presumed. So I think presumed is a wrong connotation for using with where you have the evidence, where you think probably because your immunological tests are positive or your radiological signs are positive or your AGRA tests are positive or a history of contact. I think we stand by that. So because to say that we'll give everybody anti-TB drugs, I think it's not an acceptable statement, because when you are talking to the patient, you have to be rather informing him of what you are treating. You can't say that I have the definitive proof, because we have seen people dying off, people getting blind because of ethambutol, and we have these are toxic drugs which are hepatotoxic and neurotoxic. So you can't take it's has to be given for minimum of 6 months, and for ocular TB, some of them will say, okay, go to 9 months or 12 months if you want to eliminate, because extra-pulmonary TB is treated for a longer time, because of the drug penetration issue, which will come later. But I think we should remove the word presumed and we should go by a definitive diagnosis, a presumed or a possible and a probable diagnosis. We should go by the number of tests that are positive. So we should not stop. The strongest is we should be, we should be familiar with the phenotypes, and there's a variety of these phenotypes of tuberculosis. So number one, if you see that, now if a patient of say acute anterior uveitis, okay, you start investigating him for CT chest or IGRA test, and they come positive. So would it make it a tuberculosis? No. So first, phenotypic description has to fit in with whatever is known about TB uveitis or ocular tuberculosis, and then you carry out the tests. It's not like syphilis, because it can have varied manifestations, and you do it, and then you say, well, syphilis has to be treated. But when you have a definitive, phenotype of something which is not known in tuberculosis, you would not order for CT chest or for the IGRA test. It
So
will
I
be
have
irrelevant.
Here,
Yeah.
Soumya, here I would like to add what Sir said. I think we kind of used to say maybe 10 years ago that all the patients in my uveitis clinic undergo test for syphilis and TB. I think that's not fair. Probably people misunderstood it. So you see patients with Fuchs uveitis receiving anti-TB treatment because you investigate all the patients for TB. Syphilis, yes, maybe, but TB, like Sir said, only if the phenotype is suggestive of TB, you test for TB, or you want to give treatment, immunosuppressive biologics, you test for TB. Even if it comes positive, I always make it a point to tell my fellows this is not ocular TB. The disease is JIA, TINU, or Blau, or whatever. Patient is positive for test for TB, and we are covering for TB because of the treatment. That automatically does not become ocular TB. I think that is a very important point to understand, that the positive test in any uveitis patient does not make a diagnosis of ocular TB. And the second point is like extra-pulmonary TB. You give treatment for maybe longer time. Please do not let them follow DOTS. DOTS is now a fixed dose regimen with ethambutol being given for 6 to 9 months. We have a very high report of ethambutol toxicity. Patients are coming. So I tell my patients that even if you want DOTS, take it for 2 months, and after that switch, stop ethambutol. That you will have to specify when you are referring any internist for treating TB, because Eradicate India, they are taking care of the possible resistance and all, and they are giving ethambutol to everybody without discontinuing it.
Yeah, I add one point. I support both Amod Gupta sir and Vishali Gupta. We should, whenever we write a letter to a physician to start ATT, we never write presumed ocular tuberculosis. We just mention patient has ocular tuberculosis, kindly start the treatment. And as Vishali Gupta correctly mentioned, we give ethambutol only for 2 months, followed by 2 drugs for 4 months, not ethambutol 6 months or 9 months. So presumed TB should not be, maybe it may be in our case sheets, but when we refer, it has to be like ocular TB.
Thank you, ma'am.
Yeah.
So before we go forward, I think it's a good time to take an audience question, and I hope this will encourage others also to ask questions. So one of the question, and this is from Dr. Aninda, is if the disease is paucibacillary, we are discussing about it being truly paucibacillary or not, then how do we explain paradoxical worsening with anti-TB therapy? Now, before I ask the question, let me give my perspective on this. I would think that paradoxical worsening is not related directly to the bacillary load. It is related to an aberrant immune response. There's a very nice study from PGI which shows a decrease in the T regulatory population in patients who have paradoxical worsening. So it is more about an aberrant immune response rather than a high high bacillary load which drives paradoxical worsening. Anyone else has a comment?
No, Soumya, I'd like to get in here. The paradoxical reaction, you're right, it may be an aberrant immune response, but the beauty of tuberculosis is, and that is why many of these people who are put on biologicals, why do they die of tuberculosis? Because even in these populations which do not have TB endemic, the TB organisms are present whatever state of latency they are, whether dormancy or whatever you might like to call, they are under so-called metabolic control. Now, when you are giving anti-TB drugs, you are killing them, you are releasing the antigen, this antigen is getting into the immune cells, and at the site of the inflammation, they're reaching there, targeting there, and spreading the inflammation. Okay, so a good idea would be to differentiate the two. I'll suggest, anybody can take it up. Do a PCR. Most of the patients who have so-called multibacillary, let me use the word multibacillary TB of the eye, they would possibly have a PCR positive. It is the PCR negative cases who are likely to have a paradoxical reaction. Okay, because that is mostly an immune response. It has nothing to do. And the TB drugs don't work only in the eye. They are killing organisms far and wide, all the tissues of the body. Okay, and all the bodies are sending their immune cells, towards the eye where there's an active inflammation going on and targeting that. That is what is causing, you know. And so to say that only T regulatory cells are decreased, but that we have shown already that in patients with serpiginous choroiditis, the regulatory T cells in the peripheral blood are low. And that is how these patients happen to develop tuberculosis in the first place, because T regulatory cells will downplay the inflammation and, all the time. So there is no way we can upregulate the T regulatory cells or generate more T regulatory cells.
Thank you, sir. I think, if anyone else also has questions, please post them wherever you are.
I have a question, Soumya.
Yes.
There is a patient sitting in front of you. How do you diagnose it as paucibacillary or multibacillary? Because we are talking a lot about it.
No. It's Vishali, you must understand that unless our basic concepts and basic immune mechanisms and basic microbiology is clear, simply going by ocular signs is not enough
No.
as a
So what
science.
I'm saying is, how
As
do
a
you
science,
predict?
as a clinician, you are right. You're looking at the phenotype. You are not going to be discussing the paucibacillary or
So we do not know.
non-paucibacillary.
We
No,
really do not know whether it is multi
we
or
don't know.
pauci.
But this is the difference between a clinician and a clinical scientist.
No. In context of paradoxical worsening, what I'm saying is
Yeah.
that when we look at this, there is no way we can. We tried all those CNN models and everything to predict the paradoxical worsening. And I don't think we ourselves are doing any baseline test. And PCR invariably, despite all our publication, it comes negative in 90% of patients in our center. So the problem right now, which we are facing, is when we look at it clinically, if I see a border, which is, I generally do Silverstone through this. If there is an underlying granuloma, a thick, I know this patient has more chances of worsening. Maybe that represents a bacterial load. I do not know. But this we have shown in our publications that a border which is yellow, which has a more thickness, which has choroidal, and the placoid-like lesion, in contrast to the multifocal lesions, these are the phenotypes which is likely to worsen to paradoxical worsening. So before starting, I invariably do OCT through the edge to see, what is the edge like. If there is a chance of paradoxical worsening, we will prime it with steroids before giving anti-TB therapy. And my question is, I would love to know that, is there any test we can do to figure out that those patients, which one of those are pauci and which one of those are multi, without a biopsy or this?
This is
PCR, does the high load on PCR mean it's multi or no?
No, I think that's a hypothetical question when you're treating a patient, whether it's paucibacillary or multibacillary. You know the phenotype. When you see a choroidal granuloma, when you see an exudative retinal detachment, when you see a large granuloma, okay, So those are the ones which are
Multi.
obviously multibacillary.
Multibacillary.
Yeah.
So it's
And
phenotypic.
paucibacillary is
Yeah.
when we are talking in terms of vasculitis and serpiginous like choroiditis. So these are two different set of phenotypes. And this is where, I have had a patient, very bad patient, and which I sometimes show and probably will show in the your retina fellows retreat meeting also, where this young guy who was being treated on steroids by somebody in Delhi, for vasculitis. And we did the test for TB. TB was positive, and I failed to communicate that patient has to continue with corticosteroids. And he was initiated on anti-TB drugs, and oh my God, he went blind. And because of the exuberant paradoxical reaction and multifocal choroiditis developing, coalescing, and he not only went blind, he also lost his both hips because of the vascular necrosis of the hips. So this kind of miscommunication sometimes can be. So I don't think you can predict which patient is going to develop paradoxical reaction. All need to be under watch. Typically, they are occurring at about 2 weeks, which is when the antigen release and the processing by the immune cells takes place. So we should first see the patient after initiating treatment at about 2 weeks. And only in exceptional cases, we need to not give steroids. I would always combine anti-TB with corticosteroids in these patients where we are talking of, TB uveitis.
Answering Vishali's point, think of a pulmonary cavity which has full of acid-fast bacilli, and our organ itself is smaller than the lesion. So it is natural that we can have paucibacillary when we compare with pulmonary cavitary lesion. That is the reason, even if we don't see the bacteria, we accept the term paucibacillary because we know the organ is very small, smaller than the lesion in the other parts of the body.
Yeah, so ultimately it's all boiling down to recognizing the phenotype and managing it. Yeah.
You see, they are appearing so early to us because of the symptoms.
Yeah.
Similar lesions elsewhere in the body, they will not be even symptomatic.
And we see the eye, we see, and
Like
even a
few
vasculitis
microns.
we pick up. Even the vasculitis we pick up because it is transparent and we have wonderful instruments. Whereas in other systems, it is delayed.
Yeah, an important thing is when you call back the patient at 2 weeks to look for paradoxical worsening, ask them to come with LFTs because you really want to monitor their liver function in the initial phase as well.
We do, if the lesion is near the disc or near the macula, we are very, very careful. We give more steroids and we ask the patient to come at least 3 days consecutively, or we admit the patient. If it is near the disc and near the macula, we make sure that there is no paradoxical reaction. Only then we relieve the patient.
Thank you. So, at this stage, I think it's good to push in a very controversial, question. I'll combine both of these and ask, do you think we are overdiagnosing or underdiagnosing our patients with ocular tuberculosis? Maybe Dr. JB can take it up to start with. Sir?
We are not underdiagnosing the ocular TB. The clinical criteria, the clinical features, the classification of ocular TB, that predictive signs of ocular TB has been well delineated. We know that serpiginous like choroiditis earlier we treated as a non-TB uveitis. Now we are treating as a TB uveitis, and we are getting good results. Granulomatous uveitis with broad posterior synechia, we're doing PCR and getting the good results. 68% cases in our series is positive. Intermediate uveitis, we are recognized a subtype which is causing a TB related, and we are treating with the TB and getting good results. So we might be missing some TB cases, but like amphigenous choroiditis or some other form of choroiditis. But definitely we are much better in clinical diagnosis, and we are diagnosis TB uveitis much more precisely than before.
Yeah, so I would rather say that, this is still in a phase of evolution. And if you look at the data from 20 years ago and look at the data now, serpiginous like choroiditis was a big addition which changed the way we look at ocular tuberculosis. And since then, this will keep on evolving. The imaging will evolve, our understanding of the pathogenesis will evolve. And all of these will keep on evolving. So at any stage, to call it overdiagnosis or underdiagnosis may not be a fair thing to say.
We have got HRCT chest, which are now helping us quite a bit. An extra
Yeah.
chest, we are missing a lot of TB. HRCT chest now helping in the calcified lymph node with necrosis, with CCT chest, which we are able to make a diagnosis. We are doing ultrasound of the abdomen in selected cases, and we are finding more number of TB cases. So I see we are much better off in diagnosis of TB uveitis.
Just before you move on to that, Soumya, I'd like to put a comment there on, just go back to your previous slide.
Yeah.
The West always believed, if you heard them 25, 30 years ago, there's no TB in our country. Interestingly, ever since the awareness, and I think it's the Indian group that has been talking about TB that they started seeing. And if you look at the CDC data, interestingly, extrapulmonary TB is cognizable, or they have to be reported to their database, unlike in India where it's still not a cognizable disease. So it has to be reported. So they are every year they are coming out with the details of ocular tuberculosis as a part of the extrapulmonary tuberculosis. And now it is accounting for, and this is the only data available from CDC 24 report, where 5% of extrapulmonary TB is contributed by ocular tuberculosis. And since they don't have as yet any American CDC criteria or any national criteria for the American patients, it is a underdiagnosed disease. If you look at the Michigan state data, because this ocular TB and extrapulmonary TB varies, the incidence varies in one state to the other state, even in the US. There are certain states which are much more number of TB cases, and there are states which don't have as many. So in Michigan, in the last 20 years, they've been seeing more and more of ocular tuberculosis. There is a steep rising graph. And while the extrapulmonary tuberculosis is not increasing at that rate, but TB in the eye is getting reported. Whatever criteria they use, because lab confirmation according to CDC is available only in less than 5% of the cases, of whatever the clinician there they do. But they do report ocular tuberculosis in increasing number in that country. Okay.
Yeah. Thank you, sir. I think, this will also be affected a lot by the confidence that we have in our diagnosis, when we make the diagnosis, when we convey it to the patient, and when we convey it to our colleagues. So that will gradually, bring up the numbers that we see in the epidemiology data. We'll take the remaining two questions a little bit quickly so that we have time to go through the audience questions as well. There are quite a few of them with us now. And the first one is on the anti-TB drugs and the eye, and this goes to Dr. Ratnam. And when we talk about anti-TB drugs, the pharmacokinetics of these drugs, we have to remember that it's not just about how much of this drug is coming into the eye from the circulation. It's also about how it is getting distributed within the granuloma, because the granuloma has multiple components. Dr. Amod Gupta was mentioning about this a little while ago. There is a caseous component, there is a cellular component. So that distribution in the granuloma is important. And then within that, also we have to remember that these drugs are not acting on the host cells. These have to act on the mycobacteria. And some of these mycobacteria are non-growing. They are metabolically inactive, whereas the others are actively growing cells. And these will also behave differently when they respond to the anti-TB drugs. So all these components need to be, kept in mind when we think of how anti-TB drugs would be behaving inside the eye. Dr. Ratinam, your take on this?
Yes, I will take on this.
Yeah.
Actually, all these concerns are very, very, very important. How they come into the, how much they get into the eye, as well as how much they get into the granuloma. We don't have a proper animal model and we don't have studies. Only with the clinical improvement, we are moving. If the granuloma is gradually decreasing in size and heals with pigmentation, we are sure that the lesion is healing. But we don't have direct evidence for this. Another thing is, very unfortunately, we have the same drugs for so many decades for the primary treatment. We have additional problems also. There was a very big VIP patient who used to come in chartered flight to Madurai and go back after treatment. Such a big person. He was allergic to two of the primary drugs. Then we had to give moxifloxacin and linolizide, but there is no guideline. For a primary therapy, there is no guideline, and it is a proven tuberculosis case, proven ocular tuberculosis case. So not only the questions which Basu raised, how much it is getting into the eye, we have many other challenges when we treat ocular TB. And one more very big challenge, as Dr. Vishali Gupta mentioned, we cannot blindly say that 9 months or 1 year or even 1.5 years. Maybe subretinal, very big subretinal abscess, it may need more than a year or at least a year because it behaves like a CNS TB. But all other choroidal tuberculoma, a small choroidal tuberculoma with a very small segment of vasculitis, maybe after 6 months, when it heals with pigmentation, we don't give treatment more than that. When the subretinal abscess is still reducing, but we are seeing the elevation, then we continue for 9 months or 12 months. So here also the phenotype is very important, and we don't have lab evidence unless we have an experimental animal study of granuloma, whether the drug is entering into the granuloma, all those things we cannot apply. As Vishali mentioned, when we are sitting in front of a patient, it is only the clinical sign that is going to help us. And
Right.
when it is drug-resistant TB, we cannot prove in the eye. And it is very, very difficult because we have to have a culture-positive tuberculosis to know that whether it is a drug-resistant TB or not. And we cannot use this Zine expert also in the eye fluid because of small amount of fluid we have. So there are a lot of questions and confusions in TB treatment. It looks very simple to give 6 months, but when they are not tolerant, what are we going to do? And what is the guideline given in the literature when they are not tolerant to major drugs, primary drugs, in drug-resistant, not even drug-resistant, routine tuberculosis. So these are all the challenges we have in treatment.
So we'll take up drug resistance in the next question, but before we move on from this slide, the point that I would want the others also to contribute to is why about the duration of anti-TB therapy in ocular tuberculosis. I know there have been some studies of late, but
we are not hearing you.
But when we long-term therapy for any TB, And if you look at this paper, which was published some time ago in 2007, it says there are two main reasons why we need a multi-drug and a long-term therapy. One reason is that these bacteria have inherent genotypic drug resistance. And the number of bacteria with genotypic drug resistance will be greater the more multibacillary the disease is. As against this, there is also an element of phenotypic drug resistance, which is not related to what kind of genetic makeup the bacteria has. And this is reversible, and this may change over time. Only to counter these drug resistance mechanisms, we need a multi-drug and long-term therapy for ocular tuberculosis. So what will be your take on this part?
Yeah, I again go to the phenotypic variation. As I mentioned to you, if there is a small choroidal granuloma, which heals with pigmentation over a period of 6 months, and I stop the therapy. But if it is a subretinal abscess or a bigger granuloma, which is not going for pigmented scarring, but which is slowly getting reduced, then I go for 9 months or 12 months. So we cannot know the genotypic variation, but at least we know the phenotypic variation because we see the lesion with our own instruments. But as Vishali told, ethambutol 6 months or ethambutol 9 months, we will avoid. The reason is open pulmonary tuberculosis patients are very risky to the population. So government put a blanket rule to give ethambutol for longer time. But our extra-pulmonary tuberculosis patients are not a threat to the community. But our patient is very important. He should not be losing vision because of 9 months or 12 months. So when the lesion is healing, why are we going for 9 months or 12 months?
So, just a comment on ethambutol. Dr. Navneet from Ahmedabad has this comment that 15% of the patients, and I guess this is in the context of pulmonary TB, 15% of patients are resistant to isoniazid. Therefore, ethambutol was added after 2 months of therapy. So, he says that so for ocular TB, shouldn't we add ethambutol post 2 months therapy? I think, Dr. Vishali, would you take this one?
What Navneet is saying is right, and we had discussion with AIMS group, with everybody, about the ethambutol. And there is a resistance. I was told it's 7%, but anyways, even if we believe 15, it's 4 to 7%. That's what our chief of pulmonology told. So to prevent that, they have added ethambutol for everybody because they found the risk of the toxicity in the general population was lower than the risk of developing multi-drug resistance. So they have added. Now the question is, should we also give that? I think there is a beautiful study published few years back by Monsif Kairala from Tunisia as to the patients with uveitis having an increased risk of ethambutol toxicity compared to the non-uveitis or non-ocular inflammation patients. Which means that if the risk of ethambutol toxicity in general population, for example, is 10%, it will be much higher in patients who already have the ocular disease and the compromise to the optic nerve. So given the scenario, and given that we are not talking about drug resistance here most of the times, or open pulmonary TB, right now, I think I'm not really very happy giving them ethambutol beyond 2 months. And that's the reason. I may be wrong. We may be contributing to drug resistance, but we also have to keep in mind that these are the patients who are not even receiving treatment for ocular TB otherwise, if it was not for the reason of eye. So when I'm giving it for the eye treatment, and I'm not comfortable in giving ethambutol. If, however, the patient has ocular disease and a pulmonary TB, I will not give my own regimen. I will follow whatever the GOI says and the guidelines and follow ethambutol fully. But when I'm taking responsibility, I would give it for 2 months.
Samay, I'll tell you, it is very simple. If ethambutol has to be given, has to be given. But a simple screening tool is using a color vision testing or sensitizing the patient how to see the desaturation of colors when they go around their day-to-day tasks. If they report anything where they were seeing brighter colors, bright red, and now they're seeing pinkish color and they are not seeing the same as others in the family are seeing, I think that's the time when they need to come back to you. Otherwise, it must be mandatory when you're writing anti-TB drugs, you do a color vision like we do, for some of those test for rheumatoid arthritis patient and other LE patients, for given on hydroxychloroquine toxicity. So it has to be a mandatory kind of protocol that color vision testing must be done at every visit and baseline color vision testing be done. So otherwise, you may not like to give 6 months, or you may change the protocols as per your desire. But when there is a national guideline, for giving a particular treatment, I think we should not be fiddling with it, because it may invite legal action if there is a breach of if patient gets some kind of TB related problem and he says my doctor didn't follow the protocol as was given by the government of India guidelines. So breaking
Those-
protocols is a very challenging situation. And the best thing would be to, because everybody is not going to get ethambutol toxicity, it is reversible in the beginning. So we must teach them to, sensitize them to color desensitization.
So to answer this question, we have spoken to the authorities, and DOTS, if we write that the patient has a pre-existing ocular problem and we would not like to give, they do give a broken regimen as well, even the DOTS. But you have to specify to them not to go beyond a certain period.
Yeah,
And
I
we
agree
also-
with Prasad.
Yeah,
We have also written and we
Yes.
got a permission.
they do give. It's not breaking. And the second is we also did a project of doing the color vision, but our patients with choroiditis and all, we were not very successful in monitoring, their color vision, because those with 660s and all, either you show them the lantern because they were not able to pick up on other methods.
Usually, if you have both the eyes choroiditis, it will be unusual situation. But
No.
the other eye,
But
which
the
is a good
eye
eye.
with the ocular, what Monsef has shown, the eye which has the ocular inflammation is the one which is more risk of getting ethambutol toxicity. They have shown. So, because they are not now equal. The other eye may be tolerating it better compared to the eye which is already damaged. So, but DOTS has found us a way that you
No,
can
there has to be a
continue with it.
rationale. No, why
Yeah.
should optic nerve fibers be more sensitive to toxicity if they
His
are
theory
having a
is that they are
choroidal?
already compromised.
Huh?
His theories, like Behçet's and many diseases, RNFL and all, what people have shown, they are already compromised. They are not healthy.
I think the other thing that we need to keep in mind, apart from the baseline color vision, is also the renal function, especially if we are
Yeah.
prescribing it ourselves.
Liver
So
function.
the
renal
renal function, because the pulmonologists tell us that the main reason why more patients are getting ethambutol toxicity is because a
Correct.
fixed drug combination is being given without looking at the renal function, which may be variable even in apparently healthy people. So that perspective has to be kept in mind. I'm sorry I have to stop the discussion on this question here, because we have to take the last question which we have here. And this is personally my favorite question for this session. So I hope we have enough time to discuss this. And this is probably also something that has not been addressed in the literature very much. What do you do when you have completed your course of ATT without steroids, whichever? And it could be 6 months, 9 months, 12 months, whichever. And here I would like to cite one of the finest studies on the role of ATT in ocular tuberculosis, which was published in 2007, if I'm not mistaken, by Dr. Rima Bansal and the PGI group. where a lot of patients received up to 15 months of anti-TB therapy or 18 months of anti-TB therapy, and despite that, they had inflammation. Now, while we may say that our understanding and our diagnostic criteria for starting anti-TB therapy has changed since that time 20 years ago, and a lot of factors could be affected by that. But irrespective of the duration of anti-TB therapy that you give, how do you deal with ocular inflammation that persists after completing the treatment? And I have 3 points to discuss here. One is the challenge of an alternative diagnosis, which could, of course, be non-infectious, quote unquote, but it could be another infection. And my main worry always is about atypical mycobacteria. If there is one thing that makes me the most nervous in my patients of ocular TB who are not responding to anti-TB therapy, it is, am I missing out on atypical mycobacteria? The second thing is on the issue of drug resistance and how reliable is the molecular diagnosis of drug resistance as against a culture-based diagnosis of drug resistance. And the last part is the inflammation that could be unrelated to bacteria, and this is reflected in patients who develop scleritis or episcleritis or non-granulomatous anti-uveitis after completing anti-TB therapy. So how do you deal with that? So these are the 3 things that I wanted discussed, and this is an open question. So whoever takes this.
Basu, I'll take it first, and I'll tell you that there are cases who, after completing, say 15 months or 18 months, as you said, they would remain. Now, we are all the time thinking of infectious etiology in these patients when we are treating that long. But there is something called, conversion of an infectious, because now what is happening is in the eye inflammation, all your blood retinal barriers, blood ocular barriers are broken. And once your blood retinal barriers are broken, the retinal antigens mostly, or RP antigens, are released. They are exposed to the systemic immune system, and they will go and be processed in the spleen, and they'll mount auto or immune mediated inflammatory response. So this component has not been studied, but this is what is called epitope spreading, where immune privileged organ gets inflamed, all the barriers are broken, and the sequestrated antigens are getting exposed. And once those sequestrated antigens are exposed, and Vishali mentioned about that study where they already shown that there is a molecular structural, what they have called mimicry between certain components of ESAT6 and the transporter proteins in the RPE, and also the photoreceptor proteins. So in these proteins, there is a structural homology. And once they release, once they are getting out of the eye and exposed to the body's immune system, they will mount an autoinflammatory or autoimmune reaction. Now they are, and this will lead to a chronic persistent inflammation. Only thing, how do you go about proving this kind of phenomena? It's a very well-known phenomena in autoimmune diseases, in CNS and other places, which is called epitope spreading. And this has not been evaluated as yet in the ocular tuberculosis, but it's a likely mechanism. Number 2, I think if the patient is not responding to your intended treatment, I think we need to be more aggressive. And you have shown, and we have also shown, that itself the vitreous surgery will remove all the cytokines, and it will quieten down, because these cytokines, if you allow them a quick, rapid exit from the eye, the inflammation will quieten down. Number 2, it will also allow you to, test for, by PCRs or NGS, the resistance, drug resistance. And CDS, the CDC has accepted molecular based diagnosis of drug resistance as an acceptable and easily available, quicker diagnosis of resistance. So there is no two opinions about it. It's an accepted norm. So you can do that, and we do find, and we have reported that drug resistance, and that itself is once you demonstrate drug resistance, antigen presence in the eye or DNA in the eye, you are already proving that, well, this is a TB in the eye per se, because there's no way you can demonstrate that if the resistance without being in the eye. The TB resistance develops in the periphery, in the lungs and the lymph nodes, not in the eye. There's no way it will develop in the eye per se. It has to be systemic drug resistance. So you can test it right in the eye from the ocular fluids. So I think we should be clear to be more aggressive. Maybe we need to do a biopsy. We need to, if we have the facilities for diagnosing these atypical mycobacteria and others. And I think Vishali has some experience of these diagnosing years later. The diagnosis was made by being very, very aggressive in chasing these. Yeah.
Dr. Biswas, your take on this, sir?
So I feel that whenever it is possible that vitreous biopsy or the PCR or NGS, we can do that one now. And we are doing more and more in these cases, resistant cases we are seeing. And during the in the therapy part of it is that we have now used anti-VEGF for with the moxifloxacin for tubercular granuloma, tubercular abscess that was earlier not responding to the systemic anti-TB treatment, and that response every 2-weekly injection gives a very good response. And
so I'll extend this question to Dr. Rathinam. I'll simplify it for the audience who probably do not have access to the PCR, especially for the drug resistance PCR or to NGS. So how do you take the call between chasing the organism versus chasing the inflammation in terms of you are going to do something with the antibiotics versus you are going to do something with the anti-inflammatory therapy? Where do you take the call?
I continue for 6 months, and as I told you, if inflammation is gone, well and good. If inflammation is lingering like scleritis, episcleritis, or non-granulomatous uveitis, I add steroids because it gives it supports the point given by Dr. Amod Gupta sir. The barriers are lost. So that there is evidence that there is a added inflammation, continuing inflammation, even without bacilli, maybe towards antigen. So I add low-dose steroids, which is not harming the patient, and I test it whether it helps or not. So every patient is so different. It may be one patient may not be developing any of these things, but another patient may be developing scleritis after complete treatment of TB and complete disappearance of the lesion. Then I add steroids.
If the patient is on anti-TB cover with adequate anti-TB medications, I even go for immunosuppressive agents along with that steroid.
Yes, sometimes we need that also. Like Saran, sometimes we definitely need. I agree with Biswas sir.
Soumya?
Yeah, Dr.
I
Vishal.
would like to add that it's important to answer all the three together, besides what has been said, is to look at the phenotype. And second is the timing of your intervention. If you're looking at the tuberculoma, which you have started on anti-TB treatment, and 6 weeks or 4 weeks later, you realize it's not responding, I will add host-directed therapies because my first thought will be that the treatment being given is inadequate and it needs additional therapies, like Dr. Biswas said, anti-VEGF and this. Give it more time to resolve. I will not go for immunosuppression and steroids at this point of time and follow it up. If it starts responding, well, if it is not responding, will I do vitrectomy in granuloma? Probably not, because I will be scared, going in the eye with a large granuloma. But what would I do is to add a second line of therapy, not straight away going on to drug resistance, but adding fluoroquinolones, streptomycin. Streptomycin strangely works very well for some of these granulomas, and give it another few months. Majority of the granulomas do respond to the addition of host-directed therapies, are moving on to second line of treatment. Drug resistance is not very common actually. However, if the phenotype is retinal vasculitis or serpiginous choroiditis and it is worsening, honestly, I will not think of drug resistance, because reducing the recurrence is my aim. I'm not looking at ATT to cause the primary resolution. We have to be aware of the reduced bioavailability of corticosteroids along with the ATT that we are using. So maybe the dose of steroids being used is less. So I will go up with the steroids and maybe addition of immunosuppression to treat these phenotypes, and intravitreal Ozurdex works very well in many of these situations because it's not dependent on the bioavailability of concomitant ATT. Your third and the last point, which I will take, is you have cured the disease and 2 years later, like Sir said, it's come back. Again, look at the phenotype. Many a times it's just the anterior uveitis which has come back and nothing is happening back. So you will think of the epiphenomena which Sir so beautifully explained and treated with steroids. However, if the repeat disease again is suggestive of TB, you have ruled out everything else, then comes the question of reinfection versus, reinflammation. And honestly, we do not have answer. We just go by hit and try, trying this first and then, that's the question which I do not know what to do.
Yeah, so we have two situations to make it easier for the audience to understand. One situation which you mentioned was that 6 to 8 week situation where you have, it could be any phenotype, not just a tuberculoma, any phenotype where you have been treating and you're not seeing adequate response. And probably these are also the cases where thinking of atypical mycobacteria and thinking of drug-resistant TB will be more more relevant to think of these things. You have treated with ATT for 6 to 8 weeks. But my concern is more about the patients that you have treated for 6 months or 9 months. And after completing the treatment, probably the inflammation had resolved. And still you see something smoldering on, or maybe a few months later, patient coming back with inflammation. Now, you rightly mentioned we have to look at the phenotype. Just calling everything as inflammation is probably not fair. So you have to look at the phenotype. So my question here is, we have a patient of serpiginous-like choroiditis. You have treated, say 9 months of ATT, did well. Then after 6 months of completing the treatment, comes back again with a serpiginous-like choroiditis. What do you do at this stage?
I will at this straight away not start ATT. I will treat it with the anti-inflammation and meanwhile also test for TB again.
Yeah.
That is the question. Are you going to give a second course of ATT to him? And if you ask me, in my clinical experience, majority of them do respond to Ozurdex, the recurrence, without the need for adding anti-TB drugs. But if the patient is not responding to Ozurdex and you are developing some granuloma, something, and your test for TB are positive, there is a possibility of reinfection. And that is what I told you. I really do not know how to differentiate between recurrence and reinfection. And that is the time when we try to do PET, try to find a biopsy site. And if we find something, we do repeat anti-TB drugs, but those cases are not very common, to be very honest with you. They're very rare cases. And this is the case I would also do vitrectomy if it is serpiginous to take care of the load.
Sir, Dr. Amod Gupta, sir.
Oh, I've just, Shali said, I've done so many of these vitreous surgeries in my time, and you have also reported, and we have shown the dependence on steroids from day one keeps on going down, and there's barely any side effect of microincisional vitreous surgery, especially if you don't leave the ports open. Even if it's microincisional, you need to put a suture, so there is no chance of hypotony. The only complication I've seen is hypotenuse choroidal detachment in the beginning when I was doing these, and there's a remarkable resolution of the inflammation, the serpiginous-like choroiditis, and I think it works the best that way. And and secondly, we need to also ask the patients about the compliance. Compliance is a major issue in children and in TB patients. That's something which you have to take day in, day out, every day for the next 6 9 months. The compliance may be the major issue. And if that is the case, then probably you are looking at the organism, they're persisting in the middle of the granuloma, and probably they'll need to be given again. But again, at that point of time, question will come of drug resistance, and you will need to prove it either culture, of course, relating to ocular TB is a foolish idea that will be able to culture anything from the ocular fluids. We should not be even attempting, and 6 weeks. So we should subject the ocular fluids to, if we get, lucky, we get PCR positive, we can do all the time, and we have now so many tools, Gene Expert and others, where we can find out very quickly if the organisms are resistant. And if nobody believes about it, then you should read the paper of 105 odd eyes, where we found about 7 or 8% patients are drug resistance, and we've treated them with the second line treatment, the drug resistant treatment, and they responded to that treatment. But we can't start giving them these drug resistant MDR treatment without showing one way or the other that there is actual resistance. Okay, so we should not be doing that, because these are very, very lethal drugs, very toxic drugs that we are talking about. Okay, as far as one comment I like to make about, and that has been quite bothersome, the use of anti-VEGF injections in choroidal granuloma. I don't think they work in other phenotypes. They work very well in choroidal granuloma, but the recurrences keep happening. After a few months, they'll come back with exudation. So it seems the granuloma doesn't scar as much. It doesn't die out and get scarred or calcified or whatever. So it can get reactivated, and we have now examples from Manisha Agarwal's, and we have also reported our cases where there is reactivation. The granuloma becomes active, starts reactive and exudation after months. So they will require treatment again and again. They respond beautifully well, no doubt about it, and that improves the access of antibiotics, anti-TB drugs to the granuloma once you restore the endothelial barrier of the vascular supply of the granuloma. That works very well. It makes a lot of sense. And but recurrence is an issue in those granulomas where we take the help of the host-directed therapies. I don't think there is any experience using tetracyclines or metformin or vitamin D or the host of other therapies which are undergoing trials. I have not seen any reports of those trials in pulmonary TB where these have worked, or even statins, because all these bugs which are sitting there metabolic inactive, they're feeding on the fats in the cells, and statins remove that fat from the cells, and that helps to kill the bug effectively. So that is how all these variety of these host-directed therapies will work on TB. but there is no yet final word about it. The only experience reported on anti-VEGF is from ocular TB, and there, the issue of recurrence must be borne in mind. It's not going to lead to resolution forever. Yeah.
So
I think, sir, it has to be addition. It can't be like
It's
there was-
not, no. The idea of giving anti-VEGF is because, the vascular supply to the granuloma has a kind of endothelial barrier is broken in those vessels, new vessels they are. And once you restore the balance, the flow of diffusion of antibiotics into the granuloma, the
yes.
the interstitial pressure in the granuloma comes down and the drug can diffuse more. Although only pyrazinamide will reach the caesium and no other drug, including moxiflox, or fluoroquinolones, reach the bug sitting in the caesium. And that is the biggest challenge in managing tuberculosis patients, that they are sitting in the caesium where no drug reaches in adequate concentration except pyrazinamide. That is why we need to give it over a long time. We don't know. We have no evidence in the eye of how many patients have caseous necrosis. And I think those people who are pursuing the patients might do OCT, swab source or enhanced depth imaging, and look at the structural composition of the TB granulomas to figure out if they have any, particularly those which have subretinal fluid, whether they have any caseous necrosis in the middle of the hyporeflective spaces in the choroidal granuloma. That will be a clue, but I have no idea whether it has been ever done before. But one could easily do it in the clinic and yourself, make out whether they need to. I think if there is a caseous necrosis, I think we might need to give 9 to 12 months, little longer therapy. So
thank
what
you.
they are calling phenotypic resistance, where there is actually large caseation necrosis.
Thank you, sir. I'm sorry, we have run out of time, so we need to conclude, and I also need to hand it over to Dr. Partho for the quiz question. But before that, while the goal of this session was not to provide real answers to the question, it was only to encourage critical thinking on these questions. I think some of the points that need to be highlighted about the point on mycobacteria in the eye or elsewhere is to consider ocular involvement in tuberculosis as a spectrum where there is a differential role of bacteria versus the immune response in the eye. About tissues, we had a nice discussion on whether to call it really paucibacillary or multibacillary. We were all on one, agreeing on one point that ocular TB has to be called as ocular TB, and we have to give up the practice of using the word presumed ocular TB. We had a very nice discussion on anti-TB drugs and the points that it's not just getting into the eye that matters, but also reaching the organism that really makes a difference to the outcome of anti-TB therapy. And then I hope we could encourage some good thinking of what to do, whether to chase the inflammation or whether to chase the infection, and at what stage of treatment when you're not getting the desired outcomes after anti-TB therapy. I think with this, I must thank all the panelists, Professor Amod Gupta sir, Dr. JB sir, Dr. Ratinam, Dr. Vishali. This has been a tremendous learning experience for me personally. I really hated to stop you in the middle, but I had to, think of the time. I'm sure this learning will continue. Thank you so much. And Dr. Padma, any comments from your side before Partho takes it over?
Thank you, Dr. Vas, for the excellent discussions, and important points have been brought out excellently by the panelists. We also have take-home message. Yeah, thank you so much. I hand over to Dr. Pato.
Partho.
Yes, just a minute. So thank you, everyone. It was a wonderful, actually, webinar, and I enjoyed so much. I think many of you, like me, enjoyed, and it was great learning experience for me. Thanks to all the panelists, Professor Jyotirmoy Biswas, Professor Amod Gupta, Professor Dr. Ratinam, and Professor Vishali Gupta for having with us and enlightening us with their wisdom and knowledge. We got 400 registration from 24 plus countries. I hope those who are watching live, I think you also equally found it very useful. So coming to this, USI is celebrating this. Already you know that we are celebrating the World TB Day. And with this, we had a unique feature, and that was the COP code. So this was created by Dr. Mritika Sen. It was a online crossword which was brought to you online by the Innoveda, our media partner of USI. So this code, actually, if you see, it was a ocular, I think perhaps for the first time that ocular tuberculosis or on tuberculosis, it was the first online crossword puzzle. And many of you actually, we received 91 entries for this crossword puzzle. Though few of you complained that it was a little tough, but we'll make sure that next time we'll make it much easier for you. But those who are complained is tough, they also could actually answer it very correctly. So we got 73 correct answer. Wow. So I'll announce before I go to the lucky draw for the winners of this COP code. So I want to tell you that the lucky winner will get the free complimentary registration for our annual meeting of the Uveitis Society, which will be held in Madurai. So let's go to the lucky draw. Let's see who can win.
So you're not doing anything to stop it?
No, I'm not doing it. So the winner is Dr. Aju Sunuwar. So congratulations, Dr. Aju. You'll be getting the free complimentary registration from USI for the annual meeting of USI, which will be held in Madurai. We'll send you an email and we'll get back to you very soon. Thank you, everyone.
I also invite with wholeheartedly. Welcome.
Thank you.
Thank you, everyone.
Thank you very much.
Thank you.
Thank you. Thank you,
Basu.
everyone.
Yeah.
Thank you,
Bye-bye.
Basu.
Thank you.
It was a wonderful session.
Wonderful
Yeah.
session. World TB Day.
Yeah.
24th.
Thank you.